Well, hello everyone, and welcome to the August Community of Learning. For those of you who are new to our community of learning, we meet over the lunch hour the third Thursday of every month around a different topic around dementia. If you were with us in May, you met a man named Gil who was living with primary progressive aphasia dementia. If you were with us in June, you met Mary Eck, who is the National Director of Dementia Friendly USA. Last month, we learned about the Dementia Friendly Airport Travel Initiative that is not only nationwide, but international as well. And today I'm very excited that our speaker is Dr. Robyn Birkeland. Dr. Birkeland has her PhD in clinical psychology from the University of South Florida. As a study interventionist and coach, and isn't that an interesting phrase, study interventionist and coach, at the University of Minnesota with the Families and Long-Term Care Projects team, Robyn provides support to family care partners and individuals with memory loss. She is currently working on a study coaching care partners of individuals with memory concerns and a history of traumatic brain injuries, as well as a study providing support to individuals with memory loss who are also living alone. Here to talk with us today about the newest drug available for patients living with Alzheimer's is Dr. Robyn Birkeland. Dr. Birkeland.
Thank you, Colleen. Hello, everybody. My name is Robyn Birkeland. I'm from the University of Minnesota. I work in the School of Public Health with the Families and Long-Term Care Projects team. And we recently put together a FAQ for this new medication, which I will kind of walk us through. I prepared these slides. They're a little wordy because I want to make sure that you have this information. I'll send these out to you so that you have it. I figured that typical bullet points without a whole lot of text look really nice and they're good for slides, but if you don't have that context when you're reading through it later, it may be hard to kind of put it all together. So if you do want these slides, I will be sending them so you can have them. As Colleen mentioned, my background is in clinical psychology. So I'm not a medical doctor. I don't work in a neurology clinic or have that kind of background. I do work with families who either are caregiving for someone with memory loss and dementia, or with individuals who have different diagnoses of dementia. So I have that as my background here. All that to say that I may not know some of the specifics that we need, and actually we may not know this because this is a very new medication, so no one may know it, but this is all the most up-to-date information that we have that I will be sharing today, and hopefully I'll be able to answer your questions that you have about it. So I guess I will start with a little history about this, and I was kind of laughing when this maybe just shows how little my sense of humor I have, but I was kind of laughing about this when I put it together, because like a brief history, because it really is a brief history, because it's, we're talking about July and it's August. So there's not a whole lot of history to it, but a brief history of, and I write this out so we all know how to pronounce it, but it's lecanemab, like dab, lecanemab. And so basically this drug is kind of in my mind, a replacement for the medication that came before it, which was Aduhelm. So Aduhelm was released in June of 2021. So it's hard to believe that's actually been 2 years that drug came out. And I will talk a little bit about that drug because I think, well, one, it's important kind of as in context, but also because it was created in part by the same maker, this Biogen created Aduhelm too, and kind of to compare how these drugs were created and put out onto the market. So anyways, in this case with Leqembi, which is how you pronounce the and which I will use from now on because that's what we would actually call it. With Leqembi, it was released in July of 2023. So this is very, very new. It was approved just for treating early stage Alzheimer's disease. That is in contrast with Aduhelm, which was approved for treating all Alzheimer's disease, whatever stage, but had only been tested in individuals with early stage. That was one of the many problems that people had with that medication, was that it shouldn't have been perhaps prescribed to people who had different later stage dementia when they hadn't done any testing to see if it actually did any good for those people. So this drug was made in combination with Biogen, who again did the Aduhelm, but also with another company based out of Japan, a Sai company. And they did more due diligence in creating this medication and getting it approved. Actually, just like the approval process did more diligence. And again, this isn't a medication that is designed for all stages, it's just for early stage, but they really feel that it may help slow that progression. And we'll get into some more of the details of that. It's not designed to cure it. We don't have that yet. Interestingly, though, kind of an aside here is I used to include in presentations that I would give, talking a little bit about medication and how a lot of the big pharmaceutical companies had stopped any kind of research for treatment for Alzheimer's because there were so many unknowns about it, and essentially the medications they were making were not working, and so they're spending all this money to get to a medication that did not work, and so they had kind of put it back on bench scientists to say, hey, you know what, we need more. We can't go on what we were going on, and we can't create a medication that targets what we need to target. We need to figure out what else is going on here. So there, I mean, that was something 5 years ago. So this is all kind of new stuff that has been coming out. So it's interesting to see how quickly research changes and how people come to decide, okay, well, maybe this will work and let's try this. And there's a lot of promising research there, not only for figuring out what's going on and figuring out treatments that are going on, but there's also a lot of research that is focused right now on coming up with biomarkers that can be used in a way that doesn't cost a whole lot of money and is more easily done than some of these more elaborate scans and such that we'll talk about. But they're really trying to figure out how can we tell from some basic easy tests that we can give everyone when they come into the doctor's office for their regular appointment if you have the possibility of Alzheimer's developing. And there should be something that we can find in the blood, in the spinal fluid, in scans of the brain to see, like, is there something here? And so that has been really where the concentration has been for a lot of the research, medical research surrounding Alzheimer's. And they've figured out ways to do it. They just haven't figured out ways to do it in a cost-effective manner that wouldn't set everyone back thousands and thousands, and that insurance companies would cover. So they're still working on it, but it's definitely going to be there. And they've found that you can see changes in the brain occurring 20 to 30 years before you see any signs of Alzheimer's. So any symptoms of it, that's a really nice chunk of time that they can work then on targeting. Okay, how do we prevent this from happening? What can we change in these 20 to 30 years, so that they don't develop those symptoms of Alzheimer's down the road. So that's another really promising area of research that they're working on. Okay, but back to what we're here to talk about, Leqembi. So this is a medication that it's essentially an IV infusion. It's every 2 weeks. This will be on another slide, but it's every 2 weeks, essentially could be for the rest of your life. So it's not a pill. It's not just a shot. It's an infusion. Again, I'll say this on a different slide, but it takes about an hour to do these infusions. So it's not an easy fix, but it certainly is something that they've found a lot of promise in. What the medication does, essentially it targets plaque in the brain, and it binds to it, and then it removes that plaque from the brain. I won't get into a lot of detail here unless you want to, because I'm not sure where you guys are at. As far as, I don't want to tell you things that you already know, but one of the things that they know for sure happens in every brain with Alzheimer's is you develop these amyloid plaques. Amyloid is a naturally occurring protein in the brain, but for some reason, and that's still yet to be seen why, there's either too much of it being made, or it's not being absorbed in a way it should. For whatever reason, there's too much of it in the brain. And this protein then starts to stick together. And when it does that, it forms plaques. So it has these kind of like sticky plaques, and they get in between brain cells trying to communicate. So one brain cell is trying to talk to the other one and send it a message to retrieve this memory, or to raise a hand, or to say this word. But it can't get that information, like that request, to the next brain cell to do, because there's plaque in the middle that's blocking that communication. So the plaques are essentially disrupting communication in the brain. There are some other things that happen in the brain as well, like tangles, which essentially is another situation where you have naturally occurring proteins and something gets skewed with it. These proteins are inside the brain cells. And you normally have what I like to consider like highways. So you have these parallel fibers in your brain cells. And essentially you have to kind of like drop off nutrients all down these, like throughout your brain cell. But what happens with the tau, which is that protein that's naturally occurring, is it starts to tangle, like get too much of it, tangles up those parallel fibers. So now you have knots in your rows, and those nutrients cannot get past those knots. And so your brain cells essentially are starving. So those are two things we know for sure happens in every brain with Alzheimer's. The trick is that those things can also happen in brains without Alzheimer's, but you don't see any of those symptoms. So there's obviously some other process happening, or multiple other processes happening. We only have pieces of the information, but what we do know for sure, any brain that has Alzheimer's is going to have these plaques and tangles. This medication is targeting the plaques. And again, it's binding to them, it's removing them from the brain. So it gets, it opens up those lines of communication between brain cells. So that's what its kind of point is. Again, not a cure, but it may help slow the progression. I've said this a number of times, so I won't beat a dead horse with this, but it's only for people with mild cognitive impairment or mild dementia, because those are the people who are in the testing for it. So we don't know how it would affect someone with moderate or severe dementia at this time. I imagine they'll be doing more studies to find that out, but that's the indication at this point, is only for someone with mild cognitive impairment or mild dementia, which can be tricky because a lot of times people don't go get tested or bring themselves, get identified as someone with dementia until they may be further along in the disease process. So it can be hard to find that. And this is with all the medications we have for Alzheimer's right now. They work best for someone with mild cognitive impairment or mild dementia. There is one that for moderate as well. So I don't want to say only that, but they really are targeted for that earlier stage dementia. And if you don't get in early enough, then it can be really hard to have those medications be as effective as they could be. So another little aside, just because we're talking about medications in general, is that a lot of the studies that were done on some of the medications that we had previously, their findings were, in the best case scenario, you could have 6 months of no progression. And again, that was best case scenario. And there was a lot of side effects that occurred with some of those medications that were not necessarily like serious side effects, but quality of life affecting side effects. And so sometimes, like having to go to the bathroom a lot, just feeling nauseous, those side effects for some people outweigh the benefit of being on the medication, because it just wasn't helpful. But it's interesting too, again, another aside, is that people then end up staying on medications for a lot longer than 6 months. Like if 6 months is like best case scenario, sometimes people are on these medications like Aricept and those kinds of medications for years and years. So anyways, this is very different than that because it's not a pill you can take. This is, like I said, an infusion. It's much more involved. So when they were doing the kind of initial clinical testing to try to figure out, is this something that has benefit, they would do studies, and they've done a few, but they were looking at people with mild cognitive impairment to mild early stage Alzheimer's. They were looking at those people who would get the medication, and those same category of people have mild cognitive impairment or early stage Alzheimer's, and they would not get that. They would get some placebo that may, like resembled that treatment. So that's what they were comparing. And they wanted to see, would the people who got the actual medication, who got Leqembi, did they end up doing better, faring better? And so they looked at several different things. They looked just in general about cognitive decline. They found that it slowed things down by around 27%. And I'll get into more details with that because that's kind of like a very vague, broad statement. What they looked at was a clinical dementia rating scale. And so for 18 months, they watched and they saw that there was a statistically and clinical reduction of like in the decline over 18 months. So while taking this for 18 months, they found that people who were on the placebo were getting worse, and the people who getting worse as in their symptoms were getting they were getting more symptoms, their symptoms were getting more severe, versus if you were taking Leqembi, your symptoms would be like not that they would get better, but they're like you weren't getting worse at the same rate as the other group. So it's kind of stalling that progression. So you didn't see as much decline. And that I have in here, the statistically and clinically significant is important, because statistically significant means that those groups were clearly different. Let's just put it that way. They were different. Their results were different. But what does that mean? Clinical significance is the meaning behind it. Like this actually, like the difference in their scores was clinically significant, where let me give you an example. So if you were taking a depression scale, and the highest score, a score that was 20 and above, meant that you were depressed. If you had two groups of people in that, and they were all had started with their scores at 20 or above, and then the average for one was 25, the average for the other was 25 as well. Then 18 months later, the average for one was still 25. They didn't get the medication. The average for the group that did get the medication was 23. That's a statistically significant difference, let's say. But clinically, does it matter? Does that mean anything? Because yeah, you're a little bit less depressed, but you're still over that. You're still in that range of being significantly depressed. So does it matter? By saying that it has clinical meaningful reduction here in decline, that means it mattered. This was something that like actually in their lives, their daily activities, whatever they were doing, they found that this was impacted their lives. Like the reduction in decline was that significant. So that's huge in my mind. More important than the statistically significant piece. The next study that they did, they looked at two different measures. They looked at an Alzheimer's disease assessment scale. They were looking at the cognitive subscale of that. And then they also looked at basically an activities of daily living scale. And they found, in that case, there were statistically significant differences. The people that were taking Leqembi were doing better, statistically significantly better than those who were not. But the question is, what does that mean? Like, does that mean that they were able to do one more thing than the other group? And if that's the case, how much does that really give you for quality of life, for doing well? And so that's what they're still kind of working out, that we didn't have that information at this time. So that's unclear. For the main study, I just wanted to show you the study number so you know how many people and who were the people in the study. So they had 1,734 total participants. 859 were in the treatment group. 875 were in that placebo group. There wasn't much diversity with it. Most were white, 17% were Asian, a little bit above 12% were Hispanic, 2.5 were Black. So it wasn't like a very representative range of all people. So that's kind of a drawback, but compared to the Aduhelm study, this is better. Yeah, I'll tell you more about all that in a second. I guess I don't need to throw this all up. I'll do it anyway. Okay, so gosh, I said that a lot. Early stage dementia, that's what we're looking at for this. That's what they tested in. If you think you may be, like, hey, I know I have early stage dementia, or I know my partner has it, or my family member, are they eligible to receive this? So this is what you need to go through. Yes, it has to have early stage. You're also going to need to confirm that there are amyloid plaques in your brain. So that is usually done with either a spinal tap, a lumbar puncture, or a PET scan. So those are two more invasive and less it would be nice if there was just a test that you could just, like a finger prick, or even just like, oh, I see your temperature is this is, but these involve a lot more. So you're either going to have to get a PET scan or a lumbar puncture, because they need to have this the drug won't work. If the drug targets plaque and you don't have plaque, then it's not going to work. And so they want to make sure that you have the plaque before they just prescribe the medication, which makes sense. But that's basically what that comes down to. Neither one of those are necessarily inexpensive treatments either. Those are the kind of things that we're talking about with, like, when I spoke earlier about they're trying to find ways to kind of like, what kind of biomarkers can they find that these are biomarkers that can show that you have it or not. It's just super expensive and invasive, and they're really trying to, knock it down to something a little less invasive and much less expensive. So you'll have to do that. And then they also want people to get an MRI before they're prescribed Leqembi as well, for a number of reasons. And I'll talk you through that on the next page, but they want to see that's the brain structure before you get prescribed the medication. And then they found with side effects, which we'll go through, that if you have the ApoE4 gene, that if you have that, you're more likely to get a side effect. It's called amyloid related imaging abnormalities, ARIA. You're more likely to have that side effect. And so and I'll get into what those are, but they're a little more than your typical average side effects. And so they want to see if you have that before they do this, before they give you the medication that might cause those side effects. So that could be another thing. You don't necessarily have to do that, but it's definitely encouraged, and possibly your physician would say, yeah, you have to do that before I'll give you this medication. So there's a lot of significant testing that needs to be done before you can get started on it. If you do, do all those things and get started on it, as I said earlier, it's an intravenous infusion. It's every 2 weeks, could happen forever, usually lasts about an hour, and is often done or is expected to be done like in a hospital or an infusion therapy center, a clinic. It's not necessarily something that you can just go to your primary care office and have done there. They are requiring MRI scans throughout your administration of this. So after the 5th infusion, the 7th, the 14th, but they also, if they're concerned about anything, if they're noticing that something might be, you may be getting some side effects or something that they're not expecting, they may ask you to do other MRI scans. So that's you're a minute at minimum with the one that's prior to being on the treatment. You have 4 MRI scans with your infusions. So not just, something, again, it's not just taking a pill, there's more to it. So the most common side effects are infusion-related reactions. That's by far the most common, headache. But then there's also what I talked about earlier, this amyloid-related imaging abnormality. And so the big ones with that are small brain bleeds. They found that in 17% of people who were in the study that they did in Japan. They also found 12.6% of people in that study had brain inflammation. Now, going back to the Aduhelm, just to kind of put this in perspective, those are still big numbers, but with Aduhelm, it was 40% of participants had brain bleeds, brain inflammation. So it was a much harder drug to take. So this one, in comparison, is a lot less rough on the body. So there's that. They again, I've mentioned this before, but if you have the ApoE gene, that puts you at a higher risk for having the brain inflammation. So likely they will ask for regular brain scans with that if you have that. It's not that they would rule out necessarily giving you the medication if you have the gene, but they would want to be more on top of monitoring and making sure that you're not getting that inflammation with the brain with regular brain scans. I wanted to mention too that these aren't necessarily things that are, I mean, they sound terrible. Brain bleed, inflammation of the brain sounds terrible. They're not great, but they're not, there are extreme cases of it, but they're not terrible. Like if you get it, it doesn't mean that it's, going to be, something that really impacts you. It could be, you may not even notice it and they find it on a scan. So they're not, but they are scary. Okay. What you're more likely to get are these infusion related reactions that are pretty, temporary, things like chills and fever and a rash, maybe some body aches, some flushing. 96% of those are just mild to moderate. They're not a big deal. 75% of them happened after that first infusion. So it's not necessarily something that you would have after each one. But they're pretty, they're manageable, not fun. That's for sure. And it's every 2 weeks. And if you continue to get them, not fun. But yeah, not terrible. They found that these side effects happen in about 26% of people. But the placebo group, 7% of them had the same kind of reaction. So even though they didn't get a medication that should prompt that, so maybe, maybe placebos can, because you don't know it's a placebo, it can be something that just like in your mind happened, like it physically happens, but it's because it's in your mind that it's supposed to, or you might have that. It could just be that the infusion process itself can cause that for people. Just, the idea of needles and such can bring that about. So, yeah. Now, the severe reactions, like I've kind of been, like the common side effects aren't fun, but not, you could have a severe reaction, which is, goes beyond not fun. And that, they do, it's why you're having this done in a hospital or in an infusion center. You're monitored, you have a medical professional there while you're receiving the infusion. If you were getting this or someone you knew were getting this, like to tell the doctor or nurse right away if you feel like you're and some of these are those common side effects, but just to let them know if you're feeling any of it: fevers, chills, body ache, joint pain, nausea, vomiting, dizziness, racing heart, chest pounding, difficulty breathing, like all of those are things that you want to tell them right away. They have found that if you take like anti-inflammatory medications or medications that help with like Tylenol, Benadryl, steroids, like those kind of medications that are good for anti-inflammatory, anti-allergic, like that those can be helpful. And so they may end up prescribing you or having you take those medications to prevent those kind of reactions. So cost, we are looking at a cost for a year. This is going in every 2 weeks, is $26,500, which is a bargain compared to Aduhelm, which was $58,000 to start. Then they realized that nobody was paying for it because the research wasn't there to back up that this was a safe and effective medication. So a lot of the big medical systems were like, well, we're not going to pay for that. And so then they knocked Aduhelm down to $28,000 in hopes that that would get more buy-in. But, you know, essentially that drug has kind of just fallen to the wayside, with especially with this new one kind of coming up and taking its hype with it. So so that's what you're looking at as a cost for the medication. But also to keep in mind that you do have additional costs with the brains, with the MRI scans. You have additional costs with those initial, if you do the genetic testing, the PET scan or lumbar puncture to determine if you have plaques. So there's a lot of startup there costs. And if you're paying, and let's be real, you most likely are paying for the time of the medical staff at the infusion center. So the infusion center time, their supplies, any of all the other things that always get tacked on. So it's $26,500 for the medication, but then there's, a lot more money spent on all the other side pieces to administering that medication. As far as what Medicare will cover, they will cover a portion of the cost, which was different than like for the Aduhelm. There was some, I don't know if we're going to, only if you do this, only if you do this. And it was they wanted it to be a clinical trial that someone was on for them to cover it, not just a doctor prescribing, because again, they didn't have that confidence that it was a medication that was effective. The approval process for that was different than most approval processes for an FDA approved drug. It's kind of like I can't remember the exact word of it, but like essentially a temporary approval. And they were supposed to do a lot more research on it to figure out like, okay, we'll temporarily say, yes, you can do this, but you need to come back with more proof that this works. We need more research done, and we need this information. But it was going to be over the course of years, like 10 years that they had to get that information back to them. And in the meantime, a lot of like I said, the big medical systems, including like insurance companies, were like, well, we don't want to pay for this. People didn't want to prescribe it because they weren't sure of how well it would work. And there were those significant and more common side effects, and it cost. There were just so many things that just made it a not great sell. So anyways, Medicare for this, they'll cover it if you've been diagnosed with mild cognitive impairment or mild dementia or mild Alzheimer's dementia. If you have the plaque, and that's documented, which you would need anyways to get started. So you have those two things that are already built into getting prescribed this medication anyways. They want to make sure that you have an appropriate clinical team and follow-up care. And that actually was stressed to us by other experts that we talked to, that this should be, you should have a team that is well-versed in this. It shouldn't necessarily be like your primary care physician that is prescribing this. This needs to be somebody who has a lot of experience in the area. I'll talk about that a little bit more in a bit. But then also, they wanted people to participate in a registry. So people being the doctor would, like put down the information about people in this registry, because there's still so much that we don't know about this. And this actually, if your doctor has you in this registry and can say, this is what's happening, not, it wouldn't have like anyone's names or anything, just as, a confidential registry. It can really help kind of, okay, this is what we're seeing now that this is out. These people are definitely benefiting more who have this combination of symptoms or whatever they might be able to find. It's very helpful for that. So that's what Medicare wants to see before they'll pay. They will pay, if you have like just original Medicare, it'll pay a copayment of 20% of the cost of the drug once you've met your deductible, which would be probably pretty quick considering the cost of this. Medicare Advantage will also pay 20% of the drug's cost, but it's up to whatever the out-of-pocket maximum is. So it's not like it's perfect coverage, but there is some help, which is better than the other medications that we have seen. So I wanted to talk about the Inflation Reduction Act, which was supposed to cap which does cap out-of-pocket drug costs for Medicare at $2,000, and it starts in 2025, but it doesn't apply to this medication because it applies to medications that are covered through Medicare Part D, which covers prescription drugs. This is approved through Part B, which is essentially for drugs that are administered in doctor's offices, which, I mean, that's what it is. Yeah, like it's not a pill that you can take at home. You got to go to a place to get the infusion. So it makes sense, but it's very unfortunate because it would be extremely helpful to have that cap. Obviously, even if it is 2 years out, it'd be really nice to get that. So at this time, although it's approved, it's not available. I'm sure, that's coming. They're working through, we have to like figure out the distribution of this and manufacture enough of it and just kind of like how the system is going to work before they can put it out there for people. So keep on it with people's doctors to check on availability and to see. But again, the take-home message for which doctors it is, it really should be, and this, as I said, we've heard from several experts who have stressed this. It should only be prescribed by someone who is experienced in caring for patients with Alzheimer's, and they have a multidisciplinary team. They have people that can manage the neuropsychological, neuroradiological, genetic, logistical challenges. There's so many different pieces to this. You guys, you just heard me go over all the different testing that needs to be done and the continued testing. That's a lot. And somebody who's prescribing this medication should be very well versed or have a team that can help with it, because it's just a lot to take on for a maybe a primary care doc who doesn't do as much with this kind of intense treatment that needs who has so many different components to it. These are the references. I will, again, sorry, I will send this out. So if anyone wants this or wants to check these references, these are where I pulled this from, including some experts like Sue Borson and Dr. Nautman. And then I have my contact information here if you need it. We also have a link that you can click when you're in the slides that can take you to a page that we printed of the frequently asked questions. I can also email that to you or have that in the email as well. It's like a living document, as they say. So as updates come in, we change it. So it's better to get it online, because that'll be continuously updated versus if I download it and email it to you, it's just in its current shape. And I know that we will make changes, as things happen to get that information. But yeah, so those are my slides. I guess
Thank you.
you have questions.
Yeah, let's open it up for questions. So we've already got one from Abby. What is the earliest age to start taking it, and who should not take it?
Okay, so who should not take it is anyone who does not have plaques. I identified in their brain. And also at this point, no one who is in a moderate or more severe stage of Alzheimer's. It really is that early stage or mild cognitive impairment that this has been tested on. So, I mean, I've talked about it at length, that it's a pretty intensive treatment. So you wouldn't want to take that without, without knowing that it's actually going to help. So they really want to make sure that that is something before they open this up to people in different levels of disease stage. As far as age, I don't think there is an age. As far as I know, there is no age cutoff or eligibility. It's more about the stage. Is it mild cognitive impairment? Is it early stage Alzheimer's, which are different, but yeah.
So Dr. Birkeland, at one point you said that I think that this had been tested over 6 months, but people can stay on it up to 18 months, or can they stay on it even longer if it's still effective?
Yes, they can stay on it it's been tested through 18 months actually, but they could stay on it indefinitely. They have not, that might be something that they find through time that changes. I could see that absolutely happening, and them saying, okay, we're realizing the effects of this is only good for 2 years, and this is way too much to be putting people, having people take a drug that's not helping them, that involves this much past that, but they don't know that at this point.
Excellent, thank you. Does anyone else have any questions? You can put it in the chat or raise your hand, either way, whichever you're more comfortable with. Well, people are perhaps, oh yes, Dawn.
Hi, Dr. Birkeland, thanks for your presentation. Can you give us any kind of future casting, so we know that that this drug is groundbreaking in its own way because of how it works, but what should we be thinking about for the future relative to new drugs that will come on scene?
Yeah, I really think that what we're going to find, although now that we've kind of, in the past 2 years now, we've had 2 drugs approved, which is way more than we usually get. So this might start rolling and people do more of this. It seems like the focus right now is targeting plaques. I know that there are some drugs that they are working on to target tangles, that tau protein. So there's that possibility. I feel like, from what I've heard, a lot of this, or a lot of the focus is really on those biomarkers and figuring out how to tell if someone has Alzheimer's well before, I don't know if you were on when I talked about this, Don, but there's now that research that shows that you can see 20 to 30 years before symptoms show. And so I think people are really excited about this idea that we have this large window of time that we can actively work to try to prevent it from happening. Instead of worrying about treating it, let's think about how we can figure that out easier, so that we can do that at every yearly visit. Okay, we're going to do this test. Oh, we see something now, and this is where we're going to target our treatments to making sure that it prevents it. So I think that is my gut feel, that is where that'll happen. And that would be wonderful, because then it's like it doesn't happen, right? Like, if we can stop it before we see those symptoms, then we're good to go. So we will see. But yeah, I do feel like the things right now are probably going to follow along this targeting plaque, and like I said, that there's the tangles too. But as I mentioned earlier, you can have both of those and not have Alzheimer's. So there's something else too, or there's some other things going on. So, having someone figure that piece out would be really helpful in finding a medication that can really kind of work beyond just slowing down progression, or, making sure that decline isn't as significant. We'll take whatever we can get, but yeah, I feel like there's still definite potential that we can do more.
And if I could ask a follow-up question, so
Yeah.
so many of us on the call are advocates, right, for older adults and work with family caregivers. So, what would your advice be to any of us who get questions about the drug, or should there be some messaging maybe we should all be adopting in the community? Obviously, very few, if any, folks are in the role to give medical advice, but just what do you think would be helpful as we all work in community to improve supports for people with Alzheimer's and of course other dementias? But what should we have any messages for the community around these new advancements?
Yeah, I think being able to share the understanding of that this isn't necessarily this isn't a cure. Like, we haven't found the cure, but this is something that we've seen a lot of, they've done good research on and have shown that there is a reduction in decline. So there's definitely things to be hopeful, optimistic about, but there's a lot. I think it's, when I think about it, like personally, there's just a lot that you need to do for it. There's all the pre-test workups that are a lot, the actual administration of the drug itself every 2 weeks, an infusion, like it's a lot. And so I guess kind of making sure that people realize that too, because that's going to be, I keep on comparing it to taking a pill. It's much different than that. It's going to be much more of a burden, for their time and their pocketbooks, for sure. Because even with Medicare covering it, there's a lot of money out there. So I guess I'm boiling it down to like optimism, but tempered with like the reality of it's, the logistics of it are pretty intense. And also I'd be remiss not to kind of emphasize this, that piece that the experts who we talk to are like, you make sure that people are not going to someone who doesn't have a wealth of experience with Alzheimer's, caring for Alzheimer's patients. Make sure that it is someone who has a team that can effectively work on all these different pieces, because there are so many different components to that pre-workup testing. And I think that's
makes sense.
Yeah.
Yep. Thank you.
But it does bring a moment of optimism.
Yeah.
From a clinical point of view, we work a lot with optimism in community, and getting people to and through the journey. But this is exciting that there's this moment of genuine advancement in the treatment, not the cure,
Absolutely.
the treatment. That's pretty cool.
It really is. And I think, that the last drug, there was like this wave of excitement with it. And then it was like, wait a second, like everyone kind of put the clamps on it. And it was like, this one, it feels like we can just be excited about it. Like we don't have, like, there's not that immediate kind of reaction from a lot of academics, medical experts who are saying, wait, this wasn't vetted in the way it should have been. And it's not what we think it is. So it's nice to have that for this, where it just seems like everyone's thinking, okay, this is solid. We've got something here.
So in your work with families with memory issues, how are they anticipating this? Do you anticipate that there will be people you're working with who will be put on this medication?
That's a very interesting question. So most of the people I work with are not in this state, not mild cognitive impairment, not
Okay.
early stage. However, the group that I'm working with who live at home alone, this would be that is their group. So like the people who I work with caregivers, which is mostly who I work with, you know, they're beyond this, but the people who are living at home alone would be. And, you know, I don't have that many people in that steady right now. And I don't know, like, we haven't talked about it. It hasn't come up as a thing. Like, it's not a focus of our conversations that are, but I think I will start asking about that and seeing what people are thinking about it. But it has not, that stays more focused on home safety and increasing engagement and activity and getting it. So it's a very structured thing that we do to get people to be more engaged in their communities and active.
You know what it's like when you hear about something for the first time and it goes, oh, I hadn't thought of that. And then you hear it again and you go, oh, and then you hear it the third time and it's like, maybe I should pay attention. And so for the third time now in the last 5 weeks, maybe, I have heard the terms used together, Alzheimer's and isolation, and the effect of isolation on people living with Alzheimer's. And perhaps that's something we'll do at an upcoming community of learning, because it seems to just be something I hear about in the background. And I think it's maybe something else we all might need to pay more attention to. I know I see people are having to leave for other meetings, and I understand that. I just want to give you a hint. First of all, I want to thank Dr. Birkeland for being here today. This is a lot to wrap our brains around, and it was lovely to have you here to help us do that.
Oh, thank you very much.
And then next month, we are going to have a guest from the St. Cloud VA coming to talk about a new pilot program they're doing to wrap around supports for veterans living with Alzheimer's or dementia who are still living in their homes with caregivers. And they have a new pilot program that they're working on, and that may be an excellent opportunity for us again to look at Alzheimer's from a little different perspective and move the needle a little more forward on helping people living with this disease. Anyone else have any announcements, any parting comments they want to make before we say goodbye for the day and meet next month? All right, Dr. Birkeland, the thanks are coming into the chat, thanking you for your presentation and for giving us all something to think about with optimism. So thank you so very much.
Yes, thank you, everybody. I appreciate it.
How can I get a past lecture?
Oh, so
well, I missed last one and I'd like to get to it.
And it was an excellent one. I will check with Rachel and see if she can get that to you, Miriam. Miriam, let me just quickly write down. Oh, Rachel just gave me a thumbs up, so I'm assuming she's got me covered. Great. But we will see to it that we get that to you. And as Dr. Birkeland said, we're going to send out her PowerPoints slides as well with all of the links that are embedded in there. So thank you very much for that.
Everything is really great. Thank you.
Thank you,
Miriam. All right, everyone, take good care. We'll see you next month.
Okay.
Thank you.
Bye.